Good afternoon, everyone. We're going to start with this session. It's the special session on biomedical prevention strategies, interface with behavior. This afternoon, we have the privilege to have three outstanding researchers. The first one is Sten Vermund from the United States. He's going to talk about ART for prevention. The second one is Quinn. He's going to talk about circumcision and behavior. And the last, not the least, Kenneth, PrEP and PEP. Be aware that there is simultaneous translation, English and French. And we're going to have the question and answers after all presenters have finished presenting. It's my honor to present Sten Vermund for the first talk. You have 20 minutes. Merci.
All right. A great pleasure to participate in this year's Caribbean Conference and see so many old friends. As you know, this Traxi Plenary is on the theme of interfacing biomedical prevention strategies with behavior. And I think conference organizers have picked three terrific themes because, as you'll see from my talk and Tom and Ken, there is no biomedical prevention strategy that is not steeped in behavior. And even though I don't think any of the three of us would self-identify as behavioral scientists, we know this from our experience. So my task is to discuss with you antiretroviral therapy for HIV prevention. And I'll start with Tom's work, who published in the New England Journal in 2000 the observation that in discordant couples in Uganda, there was a virtual dose-response effect as to the magnitude of the viral load and the risk of transmission to the uninfected partner. So discordant couples, the viral load predicted risk of transmission. At the same time, we didn't even know about Tom's study. Our group was doing something very similar in Zambia. And we were able to sequence all the viruses and make sure that these were transmitting couples. And if you look at the bars, I probably should guide you a little bit. Let me see if I can use this pointer. This one will work on both sides. Yeah, but I'm going to use this one just because then both sides of the room see it. So you see that the male transmitters compared to the male transmitters, female transmitters compared to the female transmitters. So the difference was between 1/2 and 1 log. But then you look down here and you look at these low plasma RNA values, and it was very uncommon for the transmitting males and females to have these low values, and quite common for the non-transmitting males and females to have these low values. So the notion of a sort of a threshold, oh, what happened? No, I don't want them to make any changes on my computer. So, especially Hewlett-Packard. So this is the interesting part. Is there a threshold phenomenon, which had been postulated by our OBGYN and pediatric friends around PMTCT? If you drive viral load down a couple of logs, can you make HIV transmission rare? And this work was I think, influential in Mike Cohen's team's work. They were interested in going the next step from plasma viral load to genital seminal as well as vaginal fluid. And I've just shown the semen data here, where if you use potent ART, you radically reduce HIV RNA or HIV DNA in the treated person. So every biologically plausible argument that antiretroviral therapy will actually be effective at reducing infectiousness to others. Now, isn't that plausible given what we know about infectious diseases in general? Sure, there's some exceptions like pneumococcus or meningococcus and autoinfection, but the vast majority of infections especially analogous to HIV, take something like Hep B or Hep C, has to do with quantitative phenomena. The more virus you have, the more likely you are to transmit. So this introduces the concept of antiretrovirals for prevention, and you're going to hear from Ken Mayer at the end of this session about whether or not we can block infection with topical or systemic antiretrovirals in the HIV negative person. That's not what I'm talking about. I'm talking about, can we treat the infected partner with combination antiretroviral therapy and protect the sexual partner? So treat the positive to protect the negative. That's what we mean by ART for prevention. If you use it in the broader term, ARVs for prevention, you might also be talking about PEP, PrEP, and microbicides. Now, isn't ART for prevention really obvious, and shouldn't we just do it? Well, you might say there are 4 unanswered questions. One, if early therapy is not good for patients, why would you do it? In other words, don't you have to show that putting a patient on therapy very early is actually good for them? Because you can't necessarily do something bad for a patient and then protect the partner. You'd like to know that. What if the observational studies are not confirmed in clinical trials? And don't get me started about all the examples in the literature where we thought we had some brilliant new insight for HIV prevention from observational studies. Remember, Carmen, vitamin A for PMTCT, I mean, down the line, and we just didn't confirm them in clinical trials. What if people won't take early therapy and adhere for many years? What if there's a very serious adherence problem? What if it works in theory, but in practice it doesn't work? And can we increase coverage metrics enough to actually make a difference to the epidemic? So it might work, but if you don't do it enough, it's not going to make an impact. So the first question was answered by Bill Popp and his colleagues. Patrice Sévère was first author in New England Journal last year. And this was the first study from a developing country that crystal clearly stated that if you put somebody on early antiretroviral, the other way wasn't working so well, I'm going to use this. I guess everybody's sitting over here anyway. So early antiretroviral therapy, you were far more likely to survive if you went on at 350 rather than going on at what was the WHO standard at that time of 200. And it wasn't subtle, and the study had to be stopped early by the Data Safety and Monitoring Board because mortality as well as tuberculosis dropped precipitously with this earlier therapy. Now, this was very compatible with what we knew from the AIDS Clinical Trials Group study. So we had strong North American evidence in a high-resource environment. But this was being done with the sorts of OIs and opportunistic malignancies, opportunistic infections and opportunistic malignancies that are prevalent in Haiti. So this made a huge impact on public policy, and WHO more or less overnight changed its policy based on Dr. Sévère and Dr. Popp's study. So we answered that question. Early therapy is good for patients. Well, how convenient. Doing the right thing for patients, which is to put them on therapy earlier, may also be the right thing for society, namely protecting others from transmission. But what if the observational studies are not confirmed in clinical trials, where there we have the HIV Prevention Trials Network 052, in which all 3 of us are deeply involved, Ken and Tom and myself. So the prevention question was to evaluate the effectiveness of ART to prevent sexual transmission of HIV in discordant couples. We also had a therapy question because we got this question for free, if you will, to evaluate the optimal time to initiate ART, whether below 250, which was the standard in the countries when we did the study, versus higher CD4 to reduce morbidity and mortality. So you could say this is a little bit like the Haitian CIPRA trial. But the primary question was the prevention question when we started the study. And we had 13 sites, and most of our endpoints were driven by the African site data. So we had 1,763 discordant couples, and the HIV positive member of the discordant couple had a CD4 of 350 to 550. We randomized those couples after we educated them about the trial and about the uncertainties, and we had about 50-50 in the 2 groups, and they all got heart, but whether immediate at 350 to 550, or when they drifted their CD4 down to 250. The endpoints were HIV transmission to the HIV negative partner, clinical events in the HIV positive partner, as well as ART toxicity. There were 28 linked infections. What do we mean by linked? It's sort of like what we did in our Zambia trial. We actually sequenced the virus to find out whether the infection actually came from the partner, because it might come from somebody outside the partnership, in which case you don't know what their viral load was. And they weren't on antiretroviral therapy necessarily, so you can't very well answer your research question by looking at the unlinked infections. So out of the 28 linked infections, 27 were in the delayed treatment arm when they hit below 250, and only one was in the immediate arm for 96% efficacy. Now, were people in this room surprised that this actually worked? I don't think anybody was surprised. I believed this was going to work since I read Tom's paper and was writing our own paper, and we had strong evidence. If you drove the viral load down, it was plausible it was going to work. But I don't think any of us expected it to work this well. This was really a remarkable impact. Within a clinical trial environment, you look at other studies for other prevention modalities, and it's not nearly this near perfection level of efficacy. Now, this is not user effectiveness in a real world setting, but within a clinical trial, it was remarkably effective. And a lot of the transmissions did occur when the CD4 was higher. So this argument that if you got a high CD4, you're probably not going to transmit, that's nonsense. It depends on what your viral load is, not what your CD4 is. There were 7 unlinked infections, and even if you include these in an intent to treat analysis, you still have about 89% efficacy. And we still have a couple of infections we're trying to sort out. But all of the ones we're not sure about were in the delayed arm. So that's going to make that even more efficacious. That's the only possibility of those reallocating those because they were all in the delayed arm. And then the clinical results confirmed the Haitian Cyprus study. There were more events in the delayed arm than the immediate arm. We saw a disproportionate impact on extrapulmonary TB. There wasn't a difference in deaths, but remember that everybody who came into the study had a starting CD4 of 350 to 550. So it wasn't a group in which you'd expect a very large number of deaths. But these results were quite dramatic and strongly indicating benefit to the HIV positive patient, even as we were protecting the HIV negative individual. Now, any pediatricians and OBGYNs in the audience? I know there are, because I see you. And this crowd wasn't surprised at all. They said, hey, tell us something we don't know already. We've been doing treatment for prevention as the backbone. We just call it something else. We call it PMT-CT, prevention of mother-child transmission. And in the United States, you all know the story of the rocketing up of the pediatric epidemic and the plummeting of that same epidemic when the ACTG 076 trial results came out. And we're happy to see data at this meeting in the Caribbean suggesting similar trends, albeit a little bit later, but from Jamaica, from Trinidad, from Barbados, from Bahamas, from many of the countries that we've looked at, we've seen tremendous strides. And even in resource-limited Haiti, we're seeing tremendous strides in fundamentally a test and treat concept. But what's different about this is you've got to treat the mom through pregnancy, ideally through breastfeeding. It's a time-limited period. But if you're talking about a sexually active individual, you're talking about treating them for life. And that's a different challenge, I would argue. So what if people won't take early therapy and adhere for years? Now, I want to remind you that all the OS52 volunteers were informed of the results when they were discovered early this year, and all of them were offered ART. Nearly all the infected members of the couples have accepted ART and are now on ART. But this trial continues, and it's continuing to assess long-term prevention impact and clinical benefits or complications, if any. It's going to continue until 2015. So we're going to we're in the process of looking at whether or not there is durability of this 96% protective impact. And we're ratcheting down the infrastructure to make it more realistic, more replicable, more similar to a real-world setting. So we'll see whether our pretty well-educated couples are going to persist in taking their medicines even though they are taking them when they don't feel sick themselves, right? That's the big difference starting your medicine when you have over 300 CD4 cells is you don't feel sick. So are you less motivated to take your medicine? That's the question we're trying to answer here. And then the final question, can we increase coverage metrics enough to actually make a difference in the epidemic? And we're doing a study in the HIV Prevention Trials Network that is based on this test, link, and care concept for HIV prevention. Putting it bluntly, if you diagnose and treat enough HIV-positive people, you might reduce community transmission to HIV negatives and actually make a substantive impact on the epidemic. So the hypothesis looks something like this. You radically expand the number of people who are tested. What's a Caribbean country that's done remarkably well in this regard? Cuba. They've been doing it for years. They are very proactive in testing. And that has helped them find positives early. Then we know that the individual who tests positive is more likely to change their sexual behavior. So that all by itself can help decrease HIV transmission, so-called positive prevention messages. So there's an issue there. Then the linkage to care is critical. Some countries do that better than others. The more integrated the health service with the public health sector, the better that linkage tends to occur. Typical examples are some of the countries in the Caribbean and some of the countries in Western Europe. The more disparate the public health system is from the curative care system, the poorer that linkage often happens, such as in the US. So treatment with ART is your goal, and do we want to treat more aggressively? Well, that's what 052 would suggest, as well as a lot of clinical outcome studies from the ACTG and other networks suggesting that you do better if you're put on therapy early, and now we know from 052 you are less likely to transmit. But then we've got the A word, adherence. And we all know what a huge challenge that is, and I'm happy to see it being highlighted in virtually every session of this conference. And if you can adhere and can maintain viral suppression, we think you're going to decrease HIV transmission. Now, I don't have time to go into the details of the HPTN 065, but I will tell you it's in the Bronx and in Washington, D.C. There are 3 nested clinical trials, one focused on positive prevention, one focused on strategies for linkage to care, and one focused on strategies for adherence. And they have a lot to do with conditional cash transfers to see whether we can do a better job if we actually pay somebody to do this than if we don't. And then there are non-randomized efforts to radically expand testing and educate physicians to appreciate the merits of early treatment. So that's the 065 study. Now, David Burns and Carl Diefenbach and I ran some numbers last year for a paper we wrote, Clinical Infectious Diseases, and we took these data from the CDC. And in the United States, if you have 100 HIV-infected persons, 21 of them are not aware of their status, so only 79% know that they're HIV positive. An abysmally low 60% of those people are linked to care, and an abysmally low 55% of those people are actually virally suppressed. So you multiply these together, you end up with only 26 of these 100 HIV-positive persons who are in care with an estimated viral load less than 500 copies. So only 26 out of 100 North American HIV-positive persons are actually suppressed. So 74%, for a variety of reasons, are not suppressed. Some of them don't know their status, some of them are not linked to care, some of them are in care but not being virally suppressed. So that's the mighty United States with all its resources doing a lousy job. And then if you read Edwin Gardner's paper in Clinical Infectious Disease this year, he took even better CDC data and he said it was 19%. Worse than our estimate. I couldn't believe it was actually a year's worth of extra data and the estimate was worse, because evidently we were using some estimates at CDC that needed to be refined. So whether you believe 19% or 26%, my point is made that it's abysmal. And when we ran these numbers for China and looked at the epidemic among men who have sex with men in China, The comparable number is probably around 8%. 8%. You're going to hear from Tom in a minute about coverage for circumcision. Well, you're hearing from me right now about coverage for antiretroviral therapy for prevention. It is low at the present time. Now, there's some good news. Mopali Das sent me these slides last night because I asked her to. and she is spearheading the San Francisco Health Department efforts to use antiretroviral therapy for prevention to radically reduce the San Francisco epidemic. And if you look at the months from diagnosis to start of ART and the months from diagnosis to suppression, they're making amazing progress in 2004 to 2008 in reducing the lag time of linkage to care. Okay? Is that clear? Because I want you to understand this slide. In 2004, you had 10 months, you had more, well, what is it? I can't read this. About a year from diagnosis to starting ART, and about 2.5 years from diagnosis to suppression. And that's now down to about 3 months and 8 months, respectively. And that's good programmatic work, Peter. That's good frontline programmatic public health work, right? And we've done that in the Caribbean, and we can do it again. Why do I pick on Peter? Now, this is virologic suppression rates, and it's gone way up. And I don't mean a little bit. I'm talking 20% to 80%. And this is 12-month virologic suppression. It's a little less, about 60% in, or 50% in 6 months. But tremendous progress. When you start rowing the public health oars in the same direction and you start integrating your public health programs with your clinical programs, you can fix testing, you can radically expand it, you can fix linkage to care, and you can educate your clinicians and get people on antiretroviral therapy. And then the virologic suppression rates by year of wait a minute, what's the difference here? Viral load. Okay, these are among people who achieved suppression, and these are among all people who are newly diagnosed and reported. And so this has not risen quite as fast, but the trajectory is in the right direction, and you're still doubling this. So they've got a ways to go with their new patients, but they're still making tremendous progress. And then this is the community viral load. This is a controversial concept because, of course, people who are not diagnosed are not in these data. So this is only people who are in the healthcare system. So community viral load may be an optimistic estimate of the kind of impact you're going to make, and we can discuss that in the discussion session if you'd like. But looking at minimal community viral load or maximal community viral load, you can't argue with Mopali that the trend is down, and that's a good thing. So at least within this pool, and by the way, it's a growing pool of people who are in care, you have a shrinking pool of aggregate community viral load. So San Francisco and Vancouver as well and other venues are making tremendous progress. And I would challenge everybody in this room, especially those of you from the smaller, richer islands, more resources, fewer patients, you might be able to snuff out your epidemic. Just find everybody who's positive and get them on therapy. Make sure they stay on therapy. You may be shocked at what kind of impact you can make with antiretroviral therapy for prevention. Bigger islands have bigger challenges, but we can ask our Cuban friends how they manage it. Now, what if we do everything at once at high coverage levels? Combination prevention. We're doing that to the HPTN 071 pop art study in Zambia and South Africa led by Richard Hayes at the London School. And we're taking these 4 evidence-based interventions: testing, counseling, condoms, as has been demonstrated to be quite successful in Uganda and Thailand, counseling for prevention of HIV positives, many studies, circumcision, you're going to hear about from Tom in a moment, combination antiretroviral therapy for prevention that I just told you about. There are many other things you could do if you had the money. Gender empowerment, PrEP, you'll hear about from Ken, STI control, behavioral interventions, treatment of co-infections. I'm not saying that you can't keep going with this list, but Richard, due to resource constraints is focusing on these 4 elements. And, you know, this is what the WHO says. You look at 04, 06, 07, 09, and for contraception, for PMTCT, antiretrovirals for PMTCT, circumcision, condom use, HIV testing, the unmet need is everything in the yellow. So don't be glib about ART for prevention. Don't just go around saying it. You've got to achieve metrics. You've got to achieve coverage rates that are substantial, that our mathematical modelers suggest are likely to make an impact on the epidemic. And we haven't done such a hot job on a number of issues that we already know about. So the HIV treatment math, as you know, there are 6.6 million HIV-infected people on ART, and it's very common in Africa for median cell counts, CD4 cell counts, to be less than 150 at the start of therapy. So we're not catching people early. We're not putting them on early. They've done a lot of their transmission damage before we've even gotten them on antiretroviral therapy. Now that contrasts to the standard in the US, which is we'll treat anybody at any CD4 count. That's the general standard at the present time. So there are 10 more million who need ART now if you use the judgment of less than 350. If you use the judgment of everybody, it's 33.3 total minus 6.7, so somewhere in the 26 million range would need it. And so we know that even with this threshold, 20 million more are going to need drugs in the near future, and we're going to need $35 billion to pay for this. So who's going to pay? Well, do you know what Afghanistan and Iraq and Pakistan wars have cost the American government in the past decade? $3.7 trillion. Trillion dollars. So it all depends upon how you look at it, whether 35 billion is a lot of money or a little bit money. And I think we could make an argument that it's a little bit of money. And here's the good news. Prevention benefits make this more cost effective. And we can now go to ministries of finance and make the argument that doing the right thing is going to save them money in the long run. And Ken Mayer and I were talking about that at the break, at lunch, that the Brazilians figured this out in the 90s before PEPFAR was even considered. And they figured that expanded treatment was going to cost them money for about 3 years, and after 3 years it was going to save them money from all of those inpatient costs and all of those people out of work and all of those orphans. It was going to save them money. So I'd like to thank people who've shared slides with me, and I hope I didn't go over my time, and I'll look forward to questions after the panel is finished with its presentations.
Thank you. Now, Dr. Thomas Quinn is going to present circumcision, the evidence.
Good afternoon. It's a real pleasure to be here. I really want to thank the organizers for inviting me to be with you for the entire duration of the meeting and for being able to present some of our recent work on voluntary male circumcision. And what I'm going to do is review for you really the biological evidence that led to circumcision being recommended as one of the biomedical interventions, and then give you our experience with rolling it out in Africa and what impact it's had on behavior, which is the topic of this particular meeting, this session. So male circumcision has been around forever, essentially. The Egyptian hieroglyphics actually show 4,300 years ago male circumcision was being done. Approximately worldwide, 20 to 25% of all men are circumcised. It's a simple procedure, but it is a surgical procedure and does confer many benefits. But as a surgical procedure, it does entail some risk. And the benefits have to be weighed against those risks. And certainly there's cultural considerations that one has to take into mind as one talks about it. I got interested in male circumcision when we were doing this viral load study that Sten very elegantly showed. Now, this is looking at female to male transmission. So these are discordant couples, which the woman is infected. The man at the beginning of the study was uninfected. They then, we looked over time, looked at viral load. This was done in the 90s. And you can see that as viral load goes up, transmission goes up. And actually, after you get above 10,000, it started to increase and then levels off, female to male transmission. But notice there's one group here, 0, 0, 0. These are the men that did not get infected independent of what the woman's viral load was. These were the circumcised men in the Rakhine population in Africa. We were shocked at this. None of these 50 circumcised men over 3 years of exposure to these infected women got infected. So clearly, this was compatible with what many other observational studies had shown. But most people would say those are observational data. You have to do a randomized trial to prove it, because maybe those circumcised men have sex different than the uncircumcised men. So you do a randomized trial. And the way you do that, you offer circumcision immediately to half of the population. The other half of the population that has volunteered to be in this study, you offer the circumcision 2 or 3 years later. So we call it delayed circumcision. And then you follow them. And here are the data. Basically, 10,000, nearly 11,000 men were circumcised. And these are the numbers in South Africa, Uganda, and Kenya. Each did the circumcision slightly different. Some were out in field settings, some were in an operating suite. But by and large, if you just look at the percent protection, 60%, 51%, 53% intent to treat analysis. If you did as treated, because some of those men didn't want to wait 2 years, so they went outside the trial, got circumcised, then stayed in the trial. And if you look at as treated, you get even higher rates of circumcision. How does that compare? Here are the 3 trials. Size of the square is the number of people enrolled. And here are all the observational studies like mine. And again, much larger box. But look at the consistency. There's absolutely no doubt that male circumcision does afford protection against HIV acquisition. And overall, if you add them all together, it's a 58% protection rate. Well, those studies, the DSMBs stopped them prematurely because of the high efficacy. It got rated as the #1 breakthrough in 2007. Who cares about New England Journal or Lancet? We made Time magazine. I mean, we were excited about this. And then we asked the question, well, how on earth does this little piece of skin around the penis, how does that have such an effect on the HIV virus? So we drilled down, what's the biological aspect? All the rest has been epidemiology. So there's 2 ways it can work. It can reduce it because that little foreskin has a lot of HIV target cells, what we call dendritic cells. And it also, by removing it, seems to have an effect on lowering sexually transmitted infections, which can serve as cofactors for HIV. What's the evidence? Here, if you just look, this is the foreskin, histopathology. A high-powered view of that shows these unusual-looking cells. These are dendritic cells, just got the Nobel Prize this past year by the people who studied them. Not from this study, I wish. But these are what HIV attaches to. It turns out the foreskin has the highest density of these dendritic cells of any other external skin piece of the body, including the vagina and the cervix. So this is jam-packed full of dendritic cells that the virus can attach to. And interestingly, if the man happens to also have herpes, even non-active herpes, there seems to be a segregation of CD4 and CD8 T cells in the foreskin because of the underlying viral infection. So these 2 are working in concert together. You've got the dendritic cells to which the virus can attach to. It migrates and hands off to the CD4 T cells. So it's a perfect setting, if you will, and if you remove the foreskin, you remove some of that. It's not 100%. We're removing some of it. So I said it could also lower STIs, sexually transmitted infections. And this is in the men that volunteered for circumcision compared to the uncircumcised men in the trial in Uganda. Genital ulcer disease reduced by 50%, herpes by 30%, pro-inflammatory anaerobes, the ones that cause bacterial vaginosis, reduced it also by nearly 30%. High-risk HPV infection, a 35% reduction. So that's great for the men, lowering STIs, lowering acquisition to HIV, but what about the women? Well, these men are having sex with women. So if you lower STIs, you lower sexually transmitted diseases in their female partners. And so we looked at the female partners of the men who were circumcised compared to the female partners of the uncircumcised men and compared the rates of infection over 2 years. Genital ulcer disease down by 25%, trichomonas 50%. Severe bacterial vaginosis, because we're removing these anaerobes in the men, you start to reduce bacterial vaginosis. And fortunately for women, high-risk HPV infection, which causes cervical cancer, is being reduced by 25 to 30% without the vaccine. So this has huge medical benefits. And this just shows you some of the HPV data. Shown in the light blue are the circumcised men, the uncircumcised men, followed for 2 years who acquires high-risk HPV or multiple high-risk HPV. And you can see very statistical differences between those two groups. What about the women? And also looking at the viral load. If you reduce HPV viral load, the shedding of human papillomavirus from a man, you are going to reduce the acquisition of HPV in the female partner. And look at this, here's at enrollment, they're about the same. Here it is at 2 years. We have dramatic reductions in HPV secreting virus in the circumcised group, the intervention group, compared to control. Dramatic differences. And cervical cancer is one of the #1 leading causes of cancer for women in the developing world, and that includes the Caribbean. So is this an expensive intervention? It's a single one-time event. That's it, and you're done. Well, it's about $30 to $60 for an adult. For an infant, $5 to $10. In the African context, not much different here. Cost per infection averted, anywhere from $150 to $900 over 10 years, depends on the HIV incidence. Huge cost savings, could prevent 5 million new infections if rolled out appropriately. So WHO, UNAIDS start to make recommendations. This is 2007. Should be now recognized as an additional important intervention to reduce the risk of heterosexually acquired HIV infection in men. Notice they didn't say in Africa. So you've got to ask your question, what are your policy people doing here in the Caribbean to recommend this? I did a little random survey out in the break, and everyone said, I don't know. I said, what % of men are circumcised in the Caribbean? The answer? I don't know. I mean, I'm looking at my colleagues to get some answers from Haiti, maybe, but it is not even talked about. So here is this great intervention that we're rolling out in Africa, I can tell you, and I'm sort of getting this ambivalent feeling here in the Caribbean. Ooh, circumcision, I don't know. Anyway, I hope we can debate that in our question and answer period. But in Africa and other places, big thumbs up, this thing works. And here, Tony Fauci showed this slide, and I pulled this one out. Sten just talked about treatment as prevention. And so what is the task ahead? You know, results are in from 2007. We're 4 years out, folks. They're in Africa, we count the number of people that are estimated to be uncircumcised. It's about 30 million men. So PEPFAR is providing full funding for circumcision in Africa, the PEPFAR countries. And there are several series underway, whether they get counseled and they go get group medical education, then some individual counseling. Are you really ready for this? Because we're going to take something off of you. And then they go through the procedure, and it's done in these open tents. It is quite low risk. It's not risk-free. There are some side effects. There's some bleeding. There is some break of sutures if it's done by sutures, and some other means. But by and large, in our studies at least, and now in the rollout, 98% completely safe. What about that 2%? Well, it's usually bleeding, some trauma, and a little bit of pain, but not much more than that. But now we have other types of ways of doing the intervention. This is called the Shang ring. It's actually essentially independent of surgery. If you're really that concerned about it, you put it on, the guy comes back a week later, and you take off the sort of black foreskin. It's been a vascular necrosis, just comes right off, and no bleeding, no complications. Studies underway to see how well this obviously works. So it says here when we did this is in Rakai in Uganda where we work, 15,000 male circumcisions have been done since the trials ended. And I want to give you some of the results and the effect on male behavior. So when we started out, we had 20% of the male population was circumcised. Why? Because they're Muslim. Muslims do it as a religious culture, as do the Jews. And then we did the trial and then post-trial. We're now up to close to 50% of our male population being circumcised. Who's getting circumcised? Interestingly, it's the adolescent boys coming in. And they're, I was just recently there, and I couldn't believe they said I'm 18 years of age. I said, you are not. You're 11 years old, and stop lying to me. But they want to have it done. They're smaller, younger than, they haven't started sexual activity. That's the best time to really get it done. And I loaned this slide to Dr. Fauci and he showed it here in his opening. This is 4 years out. We're looking at the men who are circumcised, the men who are uncircumcised, who did not want to be circumcised. We have an effectiveness, because now we're not efficacy, we're actually looking at effectiveness in the community, and you can see it's 68%. So very effective, durable, single intervention, not dependent on adherence to taking drugs or other types of things. This is really something we should be grabbing onto. If this was a vaccine, we wouldn't be hesitating. But it's not a vaccine, it is surgery, and men tend to be a little skittish when they start talking about their privates, I guess. I don't know. But in any event, let me show you some of the results of our follow-up. So here's the non-Muslims who were uncircumcised, and this is the incidence in our population right now. So it's come down over the years. It's 1.1 in the men. In the non-Muslim circumcised men, it's 0.5%. This is of the uncircumcised men. And then of the Muslims, almost identical. Just a slight difference, but it's not statistical. So we are seeing a dramatic reduction. And here it is shown here. Here's the trial, post-trial. Here is the incidence in our population. Wouldn't you like this in all your countries? With one single intervention. And then if you couple it with what Sten was just talking about and what you're about to hear from Ken, you really have a home run. And maybe we'd be done with this epidemic. Now, what about risk compensation? That's the title of this talk. Are these men who get circumcised say, aha, I have a permanent condom now and I don't have to, worry about things? Well, we decided we better look at that. Now, I will preface my remarks before you see the data that the men who get circumcised get heavily counseled. They come in and we tell them all about HIV and what it takes to get infected and that we're going to take this foreskin off, but it's only 60% effective. You still are running a 40% probability of getting infected. You've got to use condoms. They get all that counseling. The uncircumcised men aren't coming in, and they're not getting that kind of counseling. So there is an opportunity to do counseling to your patients that are coming in to be offered circumcision. So here is numbers of sex partners, the distribution in Rakai in the past year on a questionnaire during the post-trial period, 07 to 10, by male circumcision status. Do you see circumcision higher than the uncircumcised? Statistically different? No. These men are behaving just like the uncircumcised men. There's really no major difference there. Here is looking at number of sex partners reported by the non-Muslim men before and after availability of male circumcision. Here's post-male circumcision. We're really not seeing one group different than the other group. So we haven't increased their disinhibition by giving them the circumcision. This looks at the last trial visit to a post-trial visit 12 months out. And it looks at numbers of partners, just another way of looking at this. So some of these men have aged and are starting to have sex, and that's what this is. This is no sex partners. Here it is here, having some sexual partners, and up here more than 2. And these are the men that opted for male circumcision. For those who said, no, I don't think so, here are their numbers. You can see there's nothing statistically different here. So then we looked at what about the number of non-marital sex partners, having sex outside of the marital partnership. And we didn't see any difference post-trial in those who got circumcised. Now, interestingly, of those who opted out, we actually saw a tiny difference, but not much, and not statistically different. So, and then this is looking at condom use, most important parameter to look at. So up here is always using condoms. Here, and if you just stay here with always using condoms, it looks about the same in those who got circumcised. For those with no male circumcision, always using went down, went from 52% to 35%. So there's some slippage here on condom use in the uncircumcised men. But by and large, the message I want you to walk out of here with is offering circumcision offers a decrease in susceptibility to HIV, and it does not or is not associated with an increase in risk behavior in those men who got circumcised. So now you got to say, and this is a lot of people ask this question, you're taking a piece of this man's genitals off. Is this affecting his sexual satisfaction or dysfunction in men? There are people called the intactivists, all right? They believe man was born this way, he should stay this way. That's the intactivists. So we surveyed the men. You know, sexual satisfaction. Here's the intervention group. Here's the control group. Of course, they're not going to say that we didn't do anything to them, so they stay about the same. And here are the percents as they lay out. So 98% as sexually satisfied before, you know, compared to when they were uncircumcised and were circumcised. But what about the women here? You know, now something's happened to their male partner. How does she feel about this? Let's look. The women say they're more satisfied that he was circumcised than not. No, actually, no change is 57%. 39%, 40% here said women's sexual satisfaction after male circumcision compared to before. So, you know, you have a before and after, you know, the case control analysis here. Less satisfied, 3%. You can't win 100% of the time. It's like going to the casino here. So the main reason for increased satisfaction when the women were asked is that the man was cleaner, increased hygiene. Very interesting results. So I'll close there because I want time for active discussion. I have to thank all the results I'm giving you really are from the Rakai study group. Ron Gray and Maria Wayward led those initial trials. The statisticians who do a lot of the work, I showed you some of the work of Jianrong Kang on the sexual behavior, and many of these other people all helped in the laboratory. This is the Rikai Health Sciences program. Wonderful group of Ugandans, very committed to controlling the epidemic there, as we have heard from Yesco and many other places. So thank you very much for this opportunity.
Thank you so much, Dr. Quinn. Now we have the opportunity to have Dr. Kenneth Mayer, who is going to talk about pre and post-exposure prophylaxis.
Thank you. Good afternoon, everyone. It's really a pleasure to be here in Nassau with so many colleagues in the Caribbean who are doing such wonderful work on the front lines. So what I'm going to talk about today is, I think, more of a work in progress than the first two talks that you've heard, but I think it's very exciting nonetheless. So the bottom line to today's symposium is, over the last few years, we have new tools to prevent HIV. Sten talked about the use of antiretrovirals in infected people and the prevention benefit. I'm going to focus on uninfected individuals. I'll also talk about topical microbicides, because as you'll see, they really are part of a continuum. So the first question, in a resource-constrained environment, everybody has to ask, we have HB 10052, we have proof of concept. If you treat people early, you're going to have the potential to decrease the epidemic. But there's the real world as well, which is that many couples have not disclosed to each other. There's still stigma about testing and revealing HIV status. And there's some populations where the epidemic is spreading most rapidly that may not have defined partners and may not know partner status on a regular basis. So that we can't necessarily say either or. Clearly, getting people on treatment is a very important goal. But the idea that PrEP may diminish treatment, Tim Hallett from Imperial College just had a recent publication in PLOS One basically saying, in the South African epidemic, if you were able to have the resources to do both, you could have a much more dramatic effect so that they could actually act synergistically. But the questions where the field is going are, number one, can less frequent dosing be comparatively effective? Can the use of new agents, so that you'd have some drugs for treatment, some drugs for prevention? And then this issue, is it better to give the drugs topically or to give them orally, systemically? The ideal drugs, we don't necessarily know that we have the ideal drugs now. Tenofovir has been developed for a longer time. There were early animal studies that showed its role for chemoprophylaxis. Has very high genital concentrations, so it has a lot of favorable characteristics. But as I'll show you in a little while, there are a bunch of new agents that are undergoing early studies now, and it could be 5-10 years from now that we'd be using different agents for chemoprophylaxis than for treatment. But the relevant issues are, what are the concentrations that these drugs get in the various parts of the body that may be exposed to HIV? And then there's formulation issues about covering all relevant surface areas. You'd like to have drugs that have a high barrier to resistance. So for example, FTC or 3TC alone, we'd have a lot of concerns about. But as a second drug, perhaps that may make sense. And that was the drug studied in a number of the chemoprophylaxis studies, the combination of tenofovir and emtricitabine. And clearly, here as throughout the world, we have to find ways to make these agents available and affordable. And I'll talk to you a little bit about cost benefit at the end of the talk. So the first use of antiretrovirals for prevention, with the exception of the mother-child transmission data, was the use of post-exposure prophylaxis. Those of you who are healthcare workers know that there are guidelines. The CDC promulgated these guidelines more than a decade ago. They were not based on a randomized controlled clinical trial. The size would have been too huge. It was based on retrospective studies of national programs in the US and Canada, several countries in Europe. It was based on animal model data. But what are the lessons from post-exposure prophylaxis that may inform the use of pre-exposure prophylaxis or topical microbicides? And there's several. Michelle Rowland and colleagues at the University of California, San Francisco, in the health department there, developed a model program of post-exposure prophylaxis for high-risk individuals that was coupled with counseling. And they were arguing against historical controls, which is always a little bit tricky in research, but they basically said, we think that people after this program are decreasing their risk, and it's much better than when people just came in and got the drugs by themselves. But that means more resources, that you have to have an intact counseling program for post-exposure prophylaxis. Another very interesting study that was conducted in Rio de Janeiro by Mauro Schechter and colleagues was following a group of men who have sex with men. And the initial study was not a post-exposure prophylaxis study. It was just following them for their behavioral risk and seeing if they responded to counseling. So he had the idea, and this was before tenofovir was widely available, to use AZT3TC starter packs, basically Combivir, and the men were given 4 days worth of medication and told, we'd really like to see you within a day or two, but we know weekends and holidays happen, but come in as soon as possible after you've had an exposure if you're taking this medication to protect yourselves, because we want to monitor you to make sure that you have no laboratory abnormalities at the beginning, and then we want to see you over time. So there were about 200 men in the study. About a third of the men didn't take the medication but were risky, and 10 of those men became infected. Another third of the men heeded the counseling message and weren't risky at all during the subsequent follow-up period. And the other third of the men did take post-exposure prophylaxis, and there was one infection in that group. So it's 1 versus 10. It's not a randomized controlled trial, so you can say there's self-selection. The people who aren't the riskiest of the risky might have taken the medication, but it certainly is suggestion of proof of concept. Subsequent work by our group through a number of grants from the Centers for Disease Control and several companies, we were able over the course of a decade to enroll more than 550 men who have sex with men on post-exposure prophylaxis regimens through a hotline that we maintain at the clinic I work in Boston, Fenway Health, which sees a large number of men who have sex with men. And we were able to compare, again, not in a randomized fashion, but earlier use of AZT-based regimens versus tenofovir-based regimens, and found much higher rates of adherence. So there's the suggestion that tenofovir for chemoprophylaxis is certainly well tolerated in high-risk populations. So there's the debate. If you think about, apropos to Michelle Rowland's work, that this is a teachable moment. If somebody calls a hotline because they're worried that they've been exposed to HIV and they can get counseling, and that's going to change their behavior, that makes the case for post-exposure prophylaxis. On the other hand, Mauro Schechter's data and other studies suggest that a lot of people who are risky can't predict when they're going to be risky, and that's really the rationale for PrEP or for topical microbicides. That if somebody self-defines as somewhat at risk, they may not be able to predict the time of the risk, and therefore having medication on board will be preferable. The animal model data also says that you have much better results in protecting animals from HIV if they have drug on board before exposures to retrovirus than just relying on after exposure. And now we have proof of concept over the past year and a half in a stunning number of new studies. The first one, which was referred to by Dr. Fauci yesterday, was the Patrice 004 study. This was conducted in KwaZulu-Natal, the area outside of Durban, South Africa. Almost 900 women were enrolled in the study. They were randomized to a gel that contained placebo versus tenofovir gel. And the real important message is that the initial benefit was actually 50%, but the benefit attenuated over time. So at 12 months it was 50%. At 30 months it was a little under 40%. And the explanation is mainly adherence. So if you see here, if the women were at least 80% adherent, it was over 54% reduction in HIV incidence, and really no benefit if you're less than 80% adherent. So this is the ultimate challenge and Achilles heel for PrEP. Shortly after that, a study conducted in men who have sex with men, the IPREX study, was presented and then published in the New England Journal. And in this study, it enrolled almost 2,500 men who have sex with men, mainly in Latin America, but also sites in the US, Chiang Mai, and in Cape Town, South Africa. And the real take home, the overall benefit was 44% decrease in HIV incidence. But the important thing, there was subsequent pharmacologic sub-study based on samples collected. The men were seen every month on a regular basis. So TNF-DP is tenofovir diphosphate. So that's the intracellular metabolite of tenofovir, or free tenofovir in the plasma. FTC triphosphate, that's again intracellular FTC, or free FTC. So if you look here, the cases that are HIV positive, those are individuals who were randomized to the active medication and yet became HIV infected. And if you look at any of these different compartments, the visit before they became HIV infected, only 10% of the men had drug present in their blood in any of these different compartments. If you look at a control group of men, 3-to-1 matched control group of men who were equally risky and we're from the same location, similar profile, you were able to find blood and, concentration of drug in blood in almost half of the men. So if you do the math here and you say, what is the predictive value of having drug on board, how protective is having drug on board at that point in time, it's over 90% benefit. So it's a mixed message. It certainly says that overall, a lot of the men in the study were non-adherent. And this kind of chemoprophylaxis is not going to work if you're not adherent. So the real world is getting people to be adherent. But if you are adherent, there's substantial benefit. There are other populations now that have been shown to benefit from chemoprophylaxis. So the Partners PrEP study conducted by Connie Kellum and Jared Baton in Kenya and Uganda looked at couples, sort of like the flip of HB 10052. In this setting, the infected partner had higher CD4 counts and was not initially started on antiretroviral therapy. The uninfected partner was randomized to either a placebo pill, tenofovir, or tenofovir FTC. And you can see here whether tenofovir alone or tenofovir FTC, protection for men and protection for women in this setting. Another study conducted by the CDC in Botswana, enrolling young at-risk heterosexuals, the Kaplan-Meier curve basically showed a lower rate of infection, ultimately a 62% decrease in likelihood of HIV acquisition compared to individuals who got placebo. So several positive studies, all good news, but not so fast. There were two studies that were looking at PrEP orally in women in sub-Saharan Africa that had to stop early. One of them was called FemPrep, and this was only looking at tenofovir FTC versus placebo. Then the VOICE study, which I'll tell you a little more about in a minute, which is looking at gel and pills, stopped the oral tenofovir alone arm. Now we know a little more about FemPrep, but neither of these studies have yet been published and have really been fully presented in a peer review setting. So the data still are fairly sparse about why this didn't work and why things worked in the other studies that I just showed you. So the FemPrep women were asked to use hormonal contraception, yet their pregnancy rate was 9%. So that right away says to me, adherence is something of a problem in that setting. HIV incidence overall was 5%. There were also more pregnancies in the tenofovir FTC arm. So it does raise questions about adherence, but there's also data to suggest that pharmacology may be problematic as well, and I'll show you in a minute why the difference between oral and topical for women. One point to note, and I'll show you the adverse event data from IPREX where there's a fairly full data set, but the one side effect that was significantly more present in people randomized to tenofovir FTC in the first month of the study in IPREX was nausea. So if you can imagine a young woman being asked to start hormonal contraception at the same time being asked to start active medication that might make you more nauseated, you could understand why there might be differential non-adherence. But the pharmacology is also important to note. And what we have here are data from Craig Hendricks, and this is looking at, in the blue bars, concentrations in vaginal tissue. In the green, it's oral, and in the red, it's dual methods. This was a study called MTN-001, where women were followed very intensively, and at one point in the study, the same women were taking oral tenofovir. At another point in the study, they were using tenofovir gel. And what you basically see here, the tissue concentration of the intracellular tenofovir in cervical tissue, you see green here. Oral is much lower than when you apply the vaginal gel, and you don't get much of a benefit when you do oral plus vaginal. If you superimpose the kind of concentrations you see rectally for these drugs, much higher concentrations rectally after you take the medication orally. The reasons why one mucosal site gets higher concentrations than another are not well understood, but these data do suggest a rationale for thinking about why there are these variable results for women. It may be that in the discordant couple study in particular, the women may have been having fewer sexual exposures, they may have been having more partners with stable viral loads, whereas women in the FemPrep study, for example, a number of those women were engaging in transactional sex. They may have been exposed to partners who had become recently HIV infected or had more advanced HIV infection, and therefore they Therefore, the drug concentrations, which might be marginal, were not as effective when taken orally against higher viral load. There also may be higher levels of sexually transmitted infections in FemPrep. Again, some of this is speculative because these data have not been fully presented yet, but these are the kind of things that we're thinking. But it may be that for some populations, for some groups of women, for example, a gel may be preferable to a pill. And the study that is really going to be able to answer that is the boy study. So this study has now enrolled 5,000 women in sub-Saharan Africa, and the women are doubly randomized. 40% of the women are randomized to a gel, either placebo gel or active tenofovir gel. 60% of the women, then it's either a placebo pill, tenofovir FTC, tenofovir alone. So the tenofovir alone arm has now been discontinued, but this part of the study is still active, and we're all eagerly awaiting these results to see for young women in Africa, which is the most beneficial mode of prevention. I'd like to talk a little bit about some of the concerns about adverse events about these approaches. These are data from the IPREC study. So a population of men who have sex with men who had to be risky to come into the study, many people were concerned about risk compensation, that people would increase their risk-taking over time. And you can see here, and this is similar to a lot of behavioral studies with men who have sex with men, a fairly high level of the highest risk behavior, unprotected receptive anal intercourse at the outset of the study, about 60% of the men, similar in the placebo and in the tenofovir FTC arm. And these were people who thought they were taking the active medication, so they might be most likely to increase their risk. But because of the counseling, the risk went down over 3 months. Then it plateaus. And that's very similar to a lot of other studies. And this is similar also to the studies of male and female heterosexuals too, that risk tends to go down and stabilize. But the caveat is that the studies that I've been talking to you about today are placebo-controlled trials where we like to say the informed consent only a lawyer could love. I mean, the informed consent says you may be getting a placebo, the drugs may not work, the drugs may cause harmful side effects. So, and then you're seeing the counselors every month or so it's an intense environment. So what the real world profile, whether you would see an increase in risk-taking behavior or not over time, we still don't know. So this is still a work in progress. There were clinical adverse events as well, but they were fortunately quite rare. The first adverse event we were most concerned about was elevations in creatinine or other evidence of renal insufficiency. And there was a trend, but it was not statistically significant towards creatinine elevations. And in the 25 individuals who got tenofovir FTC who had at least one creatinine elevation, when the drug was stopped, the creatinines essentially went back to normal, and 24 out of the 25 were able to be re-challenged successfully and go back on medication. One person had bumps again in the creatinine and then stayed off study medication. But once again, the caveats here are this was a healthy pre-screened population to come into the study. They did not have any renal insufficiency, and because adherence wasn't the greatest, they may not, those assigned to the medication may not have been having that much medication exposure. But at least the first findings were assuring. But it was really the nausea and a little bit of a weight loss when one first starts medication. And this is important because as clinicians, if we counsel people, we have to say, you may have symptoms when you start these medications. They will tend to get better over time. One other safety signal that does have to be followed for these studies, a small, statistically significant but clinically insignificant finding in bone demineralization in the spine group was seen in the IPREC study. This is just about a 1% difference over 72 weeks, and it wasn't consistent with all bone groups. You can see here in the hip, suggestion of loss which normalized over time compared to placebo. So we don't know what happens if you're a healthy person, but you have risk factors for osteoporosis and you take these medications daily for the next 20 or 30 years. We don't know whether this is going to be a problem or not, but this obviously needs to be monitored over time. But again, there were no pathological fractures. There was nothing that was associated with a clinical event in the study, but one can say a year and a half is not a long time for follow-up. The other concern people have had is transmission of drug resistance. Once again, the environment is a very controlled environment in clinical studies, but what we found was of the people who were actually infected when they started the study, so these were individuals who had a negative antibody test at screening, a negative antibody test at enrollment, but at 4 weeks into the study, they had a positive antibody test, and then they were found to be viremic when they first came into the study. So there were 10 individuals, 8 in the placebo, 2 in the tenofovir FTC group, and in this case, there was suggestion of selection for resistance, but 3TC resistance, not tenofovir resistance. And one person in the CDC Botswana study who was in the process of becoming infected in the study did become infected with tenofovir resistant strain. So it's not that this can't happen, but it seems extremely rare with careful monitoring. What was reassuring in IPREX was of more than 100 people who subsequently became infected in the study, none of those individuals became infected with the resistant strain. So it doesn't mean that this can't happen, but it does mean that early on with careful monitoring, we haven't seen this as a common problem, the transmission of resistance. So where's the future of prophylaxis? These are the data so far. One issue is the question of, can you give less drug? Can you do peri-exposure prophylaxis? And the animal model suggests that if you dose the animals about a day before, as long as you do it 2 hours after, even 3 days before, because it takes time for the drug to be metabolized intracellularly, having that pre-dose is good. If you did it daily, it would be 100% protection, but here you get close to 90% protection with these other dosing regimens. And even a week before, as long as you do it 2 hours after. And here you can see if you do it just 2 hours before, but you wait almost a day, that's more problematic. So this issue of intermittent PrEP, the International AIDS Vaccine Initiative had one small study in East Africa, underpowered to say much, but there were a number of warning flags that people were missing postcoital doses. So there are two much more careful studies that are being conducted in the HIV Prevention Trials Network. One has finished enrollment and the data are being analyzed, and this is directly observed different regimens of tenofovir, double dosing, once a week, daily, trying to get curves to see how much drug do you have on board at different periods of time. And that work, plus trying to look at the correlates of protection from the other clinical trials, may give us a sense of the protective effect. Can you take this pill every other week? Should you just take it if you're going out on the weekend? So this is the pharmacology part. The behavioral part now is HP10067, Project ADAPT, which is going to be recruiting men who have sex with men in Bangkok and New York City, high-risk women in Cape Town. And this study is going to compare pericoital dosing. Do people know when they're going to have sex and can base their taking pills around when they're having sex? Or is it better to just say, do it twice a week and then try to have a post-exposure dose? Because does somebody know that they're going to only be risky on the weekend, for example? So these are some of the issues to think about. The other issue, there are now other studies of vaginal gels, and within the next year or two, hopefully post-VOICE and another study called FACS, we'll have enough data to get vaginal gel approved by the Food and Drug Administration. But what about rectal gel? We know that men who have sex with men and women who engage in heterosexual intercourse may often use lubrication. So there was one study already of the vaginal gel being used rectally, conducted in Los Angeles and Pittsburgh, and it wasn't well tolerated because it had a lot of glycerin, so it caused peristalsis. There's a new formulation that now has completed study that has appeared to be safe, and now there's a second study, including a site in San Juan, which is recruiting young men who have sex with men to look at acceptability. By next year, there may be the beginnings of an efficacy trial. There are other drugs that are being studied in earlier phase studies. There are non-nucleoside drugs. There are also different kinds of entry inhibitors. And I want to point out to you that Maraviroc, a drug that many of you know therapeutically, is now being studied both topically in a ring formulation and is enrolling women in Pittsburgh, Boston, and Birmingham, Alabama, and also in 12 cities in the US, an oral study of Maraviroc for PrEP in men who have sex with men, and hopefully women will also be underway soon. There are different ways of delivering these drugs, and that's a subject of future study. If you think about hormonal contraception, this is the future of chemoprophylaxis. But obviously, acceptability is the key. And just quick point, this study, MTN-01, enrolled women in Africa and women in North America. And they found that women in Africa liked the gel, tended to like the gel a lot because of its properties that felt that it improved sex. The women in the US were more focused on it being messy and preferred the pill. So I think I wouldn't generalize from a small study like this, but I do think that each product may have different applicability in different populations. There are guidelines now for PrEP that the CDC published, provisional guidelines, and there's been community forums and other messaging. This was gay men's health crisis in New York. So the question is, are gay men using PrEP in large numbers? And at least as far as we can tell, we worked with a social networking site that is the largest one for men who have sex with men called Manhunt, did a survey right before IPREX, just before, and then after IPREX. And basically, most of the men had not heard of PrEP. When we gave them information about PrEP, there was a lot of interest, but when we actually asked, had you ever used PrEP, less than 1% post IPREX had used PrEP. This was this past year. And even post-exposure prophylaxis use was quite low in this population. So the question is, can we afford to actually make these drugs available to people who are not infected? And the models are only as good as the different inputs, but there's at least several studies now that say that it can be cost beneficial, but the DECIDE study was very sobering because it said if there is increased risk compensation, even a modest amount, this can actually subvert any kind of benefit that you're going to get from PrEP. One other quick point, Mike Cohn and colleagues reviewed the fact that acute infection is a big problem in terms of forward transmission of HIV. If you rely on HIV testing and you test negative, but you actually are in the process of becoming infected, you don't want to be taking 1 or 2 antiretroviral drugs. So having better diagnostics for point of care is important. And the last issue is that PrEP can't be seen as a standalone or microbicides. We have to address the other social issues that are important, and this is as applicable as for HB 10052 treatment as prevention as it is for PrEP and chemoprophylaxis. So this is my last slide. Basically, this is the new paradigm. We have to think about how do we increase testing. Once we test, we have to think about risk assessment for the uninfected people, and some people will be the right population for PrEP or microbicides. But for infected people, it's not just getting them on treatment, it's positive prevention, it's adherence counseling, and it's addressing the panoply of social and structural issues that keep people from being adherent. Just want to thank my colleagues at Fenway and thank you for your attention.
Well, I think that you've heard 3 excellent presentations by the world's best experts. And I think we should give them another round of applause. Now, this is open for questions. Could you please go to the mic and identify yourself? Carmen.
Okay. Carmen Zorrilla from Puerto Rico. This question is for Tom. We know that adult male circumcision certainly works because of the trials. And we also know that neonatal circumcisions are easier and probably easier to implement. And we know from retrospective studies that circumcisions done in neonatal period work when males are adults, because that's the retrospective data. What's your opinion on actually conversations and perhaps, and I know that there's studies that done in Africa on the acceptability of neonatal circumcision. I don't know if people are thinking that would be one way to implement such a program.
Neonatal circumcision. It is by far cheaper, less side effects, would be the most appropriate time to do it. Is it taking off? No. Why is cultural. So the American Academy of Pediatrics has not weighed in on this, and because they will not weigh in on it, and we have been lobbying, something like half of the U.S. states will not pay for male circumcision for the poor. So Medicaid is not available for a family who wants to circumcise their baby boy. And they just say, well, the American Academy doesn't recommend it. So then the next question is, well, what about CDC? Where does CDC? CDC came out with a policy internally in 2008, which was very supportive, but has never seen the light of day. And it's partially political, that the intactivists, the activists who are against circumcision are very loud. They seem to have slowed the process down for the U.S. Now that's not happening in Africa. In Africa, I didn't get to it, but 1 million men, young adult men, have been circumcised because of PEPFAR since the results of the study. Now I said 29 need to be circumcised, so 1 million out of 29 is getting back to this very small percent. But I strongly do believe neonatal circumcision is the best time to do it. We have an editorial in JAMA. We have another one in pediatric journals. I wish we could do that. I'd like to throw it open. In Puerto Rico, what % of baby boys are being circumcised at this point? Do you know?
I'll answer for Haiti, and I'll say that in Haiti, it's only done as a medical reason for complications as phimosis. So I would venture to say, less than 2% of the population of neonatal infants are circumcised.
Yeah, young men in Puerto Rico, about 40% have circumcision, but the babies are not circumcised because pediatricians used to be the ones who did the neonatal circumcision, and they stopped doing them. So there's no one trained. And I do believe that we need to start this process, this conversation, so that we can increase the training for neonatal circumcisions and perhaps even pilot in communities where we have high prevalence or high incidence, even the babies of the mothers who are HIV positive, who will live in an environment with more HIV.
Next question.
My name is Stephen Forsyth from the Futures Institute. I had for Dr. Vermund, my question was, I was quite interested in conditional cash transfer programs, and I was hoping maybe you can discuss that a little bit more. And for Dr. Quinn, my question was, in terms of male circumcision, do you think a conditional cash transfer program would work? In other words, cash for foreskins. Would it work? And would it be ethical to do?
What are you paying, Tom? I might be interested. No, the issue of continuing of cash transfers is controversial. Julio Frank and others have had tremendous success in Mexico and elsewhere, and there are clear positive examples of where paying people to do the healthy thing is actually the cheapest way to get the healthy thing done. And we have the HPTN 068 protocol in South Africa, in which Audrey Pettifor and her South African colleagues, Catherine McPhail and others, are looking at, in a randomized controlled trial with HIV endpoints, whether or not paying girls' families to enable them to stay in school will actually prevent HIV, making it possible for them not to have older boyfriends who fund them to stay in school in exchange for sexual favors. Our 065 study has two arms in which a gift card is available, and that has to do with linkage to care. If people come to care in a prompt way and come to at least 2 visits in care, then they get their award, compared to sites in which that's not happening. So it's a site randomized initiative. And then we also have an adherence conditional cash transfer nested clinical trial, so that people who are in care who achieve suppression metrics will be rewarded. And that again is randomized to see whether it matters, whether we can motivate people by just educating them versus whether the cash actually does any good. Now the critics, as you know, since you're doing this work yourself, the critics say this is not sustainable. Ministries of Health don't have the money to be able to support paying people to do the right thing. So it is, I would say, in a research mode, and the leap from success in research, if we achieve such success, to policy may be a bigger leap than we're usually used to. On the other hand, I've warmed up to the idea maybe ministers of finance can too.
My answer is actually pretty easy, because it is a single event. It'd be a one-time cash transfer. And I'd be lined up for it. No, it's a research study. I don't know of and someone's BlackBerry. I don't know of any published studies that have looked at this, but certainly would provide an incentive. Is it sustainable? Yeah, the issue comes back. You just need to do this procedure once. So probably would be sustainable if it was built into the cost of the procedure.
Hi, I'm
Thanks. Yeah, Vanessa?
Vanessa from Haiti. Has male circumcision been looked at as a prevention into serodiscordant couples and men who have sex with men?
Yeah, so no randomized trials in men who have sex with men. The observational studies are pretty kind of split. Most of them don't show a benefit in men who have sex with men.
But
There's a sub-study, if the man happened to be only insertive, it might work. That's from Peru.
Yeah.
From Peru. But by and large, the other studies in the U.S., some observational studies, all of them, only a small benefit. It's not statistical, and it's not being recommended for men who have sex with men. The other question, the first one?
heterosexual serodiscordant.
Oh, for discordant couples, yes. Within our, where the female was positive and the male is negative, absolutely. We have been studying that.
And the other way around?
It the other way around?
Like at HIV clinics where
Yeah.
you have HIV positive men, would you be recommending circumcision
So,
for fathers and their boys
Right.
as a means of preventing transmission to their partners?
So-
Because oftentimes, they might have multiple partners outside of one faithful partnership.
Right. So, if you're looking at transmission, does circumcision decrease transmission in an HIV-infected man? The answer is no. It did in an observational study, but we did a randomized trial, actually funded by the Gates Foundation, and it has subsequently been published. It was stopped due to futility. We could not find a significant difference either way compared to the controls. So it did not appear to affect transmission. In fact, some of the men really ruined the study because they got circumcised. They were HIV positive, and before they healed, they went out and had sex, unprotected sex. They were bleeding. They broke their sutures. It was probably the worst thing they could have done to a woman. It does not decrease transmission. Now, that begs a question. If you're at an HIV clinic and you're offering circumcision to the general population, and some HIV positive men want to take advantage of this, because it does reduce STDs,
STIs, yep.
that it does do. Yep. For stigma purposes, we've been offering it to both HIV positives and negatives. We don't want the positives to be stigmatized and say, no, you can't have it. But we really intensively counsel those men, more so than the negatives, and we have them come back every other day practically, saying, you're not healed, no sex, permanent condom for you for sure. Those are issues that I'm glad you brought that up. It is an issue. Now the boys, obviously before they become positive, even if the father was positive, should be circumcised to protect them.
Thanks.
Next.
Okay, I am Clement George. I'm from the Caribbean, but live and work in Canada. I have two questions. Well, first of all, Vanessa seems to have asked one of my questions, but just an additional, it's just a comment. I attended two sessions, one here yesterday and at another time, where people are advocating for gay men to have circumcision as part of the tools to reduce HIV. And as you said, if it's not recommended, there is no evidence about it, and it probably could even be harmful. But my question actually is now is related to Dr. Vermund, and you talked about community viral load and the experience of some countries, and you actually stated Cuba. And I was just wondering, seeing how our countries operate in the Caribbean region around human rights, what kind of recommendations do you have for government officials, some of whom are in this room or maybe in this room, around rounding up people who may be HIV positive to get to know their status and what's going to be done? Thank you.
Well, a Cuban probably should respond before I do, because I'm not intimate with the Cuban program. I don't believe that a radical expansion of testing opportunities is a violation of human rights. I believe that a radical expansion of testing opportunities is very pro-human rights. For example, if I had a population with a high background prevalence of diabetes, doing some urine blood sugars and making that readily available for them would be a good thing. It'd be a good human rights thing. I feel the same way about HIV. If we have a certain proportion of people with HIV, we have extremely powerful therapies. Not only can we protect them, but if we get them on therapy, we can protect their loved ones. Then it's a human rights violation not to offer that test. So I think we should salute the Cubans for their widespread promulgation of testing. Now, I hope it's voluntary testing. I don't think you should strap somebody down and force them to draw blood or say you get a test or you're going to lose your job. But I've talking to Cubans, they've said, no, we say, look, this is highly advisable for your health, and everybody says yes. It's sort of like Singapore. There's a certain, or Finland, there's a certain voluntarism in Cuba. People have come out and done the testing without objection. And I have been told that people have refused testing in Cuba, and it's been okay. But I could be wrong on that. Now, in terms of rounding people up, the Cubans did have an unusual approach in that they had communities where HIV-positive people were brought, and that was analogous to the old quarantine approach that we had for infectious diseases, and that was seen as objectionable in many circles. And I wouldn't suggest that in the rest of the Caribbean that would be feasible. I don't think that'd be practical. I don't think it'd be acceptable socioculturally. I don't think that's going to work. But I was making the positive point about Cuba is the pro-testing policy, the ability to readily get an HIV test and get services if you're positive. In that regard, I think the Cubans have done a good job.
Santana, Puerto Rico. Tom, I like your politically correct word for men being coward, activist. We should just agree that we are just more fearful of pain than women are. So why not say it? No, this question is for Ken regarding the FemPrep.
They're wimps.
Right.
That's from the female perspective, you know.
FemPrep and voice. Can you care to speculate and expand a little bit more on the possible reasons, or are there multiple in terms of failure in women? Is it the contraceptives interaction, hormonal changes, besides the pharmacologic lower dose?
Yeah, no, it's an excellent question, and we hope that either at the upcoming retrovirus conference or certainly by next July at the AIDS 2012 conference, all these riddles may be better resolved. So they're pieces of data, and these are competing theories. So one is just the pharmacology, and there clearly are lower levels, but we don't have we don't know what the correlative protection is yet in terms of what level. There's some nice work that Slim and Quraysh Karim with Angelica Shuba did do a retrospective analysis of the data from Caprice 04 and was able to show, sort of a dose response that women who had higher concentrations had a higher level of protection, but it, wasn't perfect, and certainly we don't have that from an oral study yet. So we may have some secretions studies that come from Partners Prep and from the CDC Botswana study that might help inform, what are the true concentrations you get in the tissue. But, Tom showed some really nice data on dendritic cells, and, there are other cells that can acquire HIV, And particularly for women, there's a big debate because obviously the cervix has many more relevant target cells, but the vagina has a much wider surface area. Women who've been hysterectomized and have a stable scar at the hysterectomy site can become HIV infected. So knowing, not only the concentrations, but which tissues are most relevant for protection. So that's a big pharmacology debate. The hormonal debate, there definitely are some very good epidemiologic analyses that hormonal contraception, above and beyond the fact that women who are using hormonal contraception may be having more unprotected sex, that does increase susceptibility. And certainly a lot of the women in FemPrep were on hormonal contraception, and some of the women in voice. But and then the last issue would be who are the partners of the women. And in discordant couple study, if the partner started having a decline in his health, he would be put on antiretroviral therapy after the study originally started. So we have to go back in partners prep and see, how many of the transmissions occurred at the different CD4 strata. In FemPrep and in voice, we won't know the viral loads of the partners, but we'll know something about the women's behavior. So I think there are different pieces that we need to put together to understand whether oral chemoprophylaxis is an option for women, but is it only for some women, for example?
The very last question, Bernard.
Yes, I'm Bernard Lyoto from Haiti and Martinique. One comment for Dr. Vermund. You did a great suggestion. I've been fighting in Martinique for some years to have those rich countries be involved in treatment for prevention. They have everything there, and I'm pretty sure that you even have two islands, Guadeloupe and Martinique. We could have comparison between both. And I think this is a very, very great suggestion for those small countries. But my question is for Dr. Quinn. In the 90s, we had a survey at Gescio in the STD clinic. And at that time, we looked at circumcision. Less than 5% of male were circumcised. But I always wondered, how come that Haiti, with all those people uncircumcised, had a better evolution regarding HIV prevalence than many countries in Africa? So even without circumcision in Haiti, they were able to decrease the prevalence from 6 to 2.2%. So do you see something that can explain that?
So I think that's a very good point. And oftentimes, other epidemiologic interventions, like took place at Giesco. You did a lot of screening, you put a lot of people on treatment, there was a lot of education going on. I know you promoted condoms intensively. That I think it was, and I assume most of what you're referring to is Giesco oriented. Maybe it's whole country, but I would bet it's mostly Giesco. I think that's a compliment to all the other interventions that you have really implemented. And it was in a concentrated group. But on the other hand, let me challenge you back to the beginning days, because Bill remembers when I first arrived in Haiti, in Port-au-Prince, and it was 1982. And in the US, they were listing Haitians as a risk group because they didn't understand it. And we went down there, and for every man we found infected, we found a female infected. It was clear that there was a lot of male-female and female-male transmission going on right from the very start. One of the reasons you could postulate is the lack of circumcision in the population made the men just as susceptible to this virus as the females, because that's the way we saw it when we went to Africa, and we reported that. Heterosexual transmission and equal male-female, female-male transmission, one-to-one distribution. And in fact, I was looking at Peter's slides. Peter Figueroa was giving distribution of the epidemic in the Caribbean, and I was fascinated to look, okay, what is the male-female distribution? And in some places you showed it coming together, and it's quite equal. And I was thinking one of those reasons might be low male circumcision rate, that it has enabled this type of equal distribution. So my compliments to Giesco for implementing other means of slowing the epidemic. And although we talked about 3 primary methods, all the other methods apply and are very powerful. And I was thinking about the Caribbean. You know, why is it not promoting circumcision? It's all situationally based in that if you don't have a high incidence it's a low prevalence, and young boys and even young men don't feel at risk, and they're going to offer themselves up for a surgical intervention when their probabilities are much lower than if they had been a male in Uganda or a male in some other Zambia or South Africa, where 5 million people are infected, and there's, as you grow up, there's a big risk. They probably don't feel the risk in a lower prevalence, lower incidence population that we see. And that's why I'll come back to Carmen and say, well, that may be the case, but they still run a risk of getting infected. Let's implement neonatal circumcision as a more common policy. Protect the young boy at the very earliest age, doesn't cost much, very little side effect. And you've offered that young boy a chance to, at least lower susceptibility to HIV. Thank you.
Very last one.
Yeah, just a short comment. I'm Wendy from Suriname. And twice the Ministry of Health offered men and boys to be circumcised. We did it, I think, 2 years ago and this year. And both times we gave 500 men and boys the opportunity to come as HIV prevention intervention. And actually, it was very good. Even more than 500 wanted to come. However, when looking at the reasons why they came, they admitted that they came for religious reasons. But it was free, of course. So you believe based on your religion that you had to be circumcised or that your son had to be circumcised. So you come and you get the circumcision because it's free. So even though we would really look further into it, and I'm happy for the results because, of course, a few persons were concerned about their behavior. So I'm happy for the results that you shared. We would also like to look into ways to get those to come to get circumcised, believing that it can be an HIV intervention and not just because of religious reasons.
Great, thank you for that comment. And I also know in the Dominican Republic as well, they're also doing a similar feasibility offering circumcision, and we'll see what the acceptability of that is. But it sounds like it's acceptable in Suriname. Yeah, thank you.
Essentially, this will close this session. Before we do, I'd like to thank all our 3 experts. I'd love to take all 3 of them to our Ministry of Health in the Caribbean to push for all those 3 interventions. In fact, I don't know if you realize, they presented data that for the last decade they've shown first evidence that countries, for instance, that had lots of men circumcised had low incidence of HIV. Then clinical trials demonstrating that circumcision worked. The very same thing for HIV. Tom Quinn showed that viral load was associated with HIV transmission. ERT decreased HIV transmission. And then clinical trials clearly showing that it works. Now we need to move to the next step, which is scaling up, that will bring another hurdle, major one, that is adherence. And we need also to look at cost effectiveness of each intervention, different setting, to find out which one would work best. Thank you very much.